Thank you for joining us today to this web series, which is called Tuesday Lunch with Rita. And this web series are meant to talk about immunological and rheumatological related topics and discuss about them. And today we have an important person on autoimmune diseases from France, which is who's Jérôme Honorat, who's going to talk how we diagnose the autoimmune encephalitis. And I will share with Thais Armangué. I will let her present ourselves.
Good afternoon. I'm Thais Armangué from the Neuroimmunology Program in Barcelona, and today we are delighted to listen Professor Honorat.
And I myself is Kumaran Deiva. I'm a pediatric neurologist, and I'm working also in Kremlin Bicêtre in Paris. So now Jérôme Honnorat is the head of department of the neuro-oncology department in Lyon. He's also the head of the National Reference Center for Autoimmune and Paraneoplastic Encephalitis. And it's really a great pleasure to listen to you, Jérôme, and the floor is yours now.
Okay, thank you very much, Kumaran and Thais, about your introduction. And so I'm pleased to show you this presentation on the autoimmune encephalitis. And so first, what an autoimmune encephalitis? It was not obvious. The first cases have been described in 1960 and 1968 by Brierley and Corsellis about patients with temporal seizures, confusion, and anterograde amnesia, and all of them had an associated cancer. And it was lung cancer in most of the patients that was present in the same times of the limbic encephalitis. And so they described paraneoplastic limbic encephalitis. After this first description, these patients seems to be very rare and was characterized by very acute and very hard clinical presentation with patient that was bedridden without good evolution. And so in the next years, in the first 90s, other authors described autoantibodies associated with paraneoplastic neurological syndromes. And it was the start of the description of autoimmune encephalitis in patients with different kind of syndromes associated with autoantibodies and with different kind of tumors. And we started to describe patients with paraneoplastic neurological syndromes. You can see a study published in 2010 that was the results of networks in Europe who was active between 2000 and 2008 in 11 countries and 22 centers. And you can see that we identified less than 1,000 patients. So it was clear that it was a very rare disease. HU antibodies was the main autoantibodies described in the patient with YO, Y, or CV2. But you can see for CV2, for example, it's less than 60 patients described in 80 years in 22 centers in Europe. so it was very low. And you can see that the most frequent symptoms was subacute cerebellar ataxia and sensory neuropathy. Both of them was 50% of the patients, and limbic encephalitis was only 10%, less than 100 patients, so very rare. In fact, it was due because at these times, there is no specific biomarker described in association with limbic encephalitis. And it's why there is so low rate of patients described with limbic encephalitis. With the time and after many years, it was clear that paraneoplastic neurological syndromes was only the top of an iceberg of autoimmune disease, not always linked with a particular cancer. And this story particularly started with the description by Angela Vincent of potassium channel autoantibodies, but at the end, we know now that there is no antibodies directed against the potassium channels, but against other proteins like LG1 or Casper2. And particularly in 2007, with the work of Joseph Dalmau, who was in UPenn in Pennsylvania, who described paraneoplastic patients, women with ovarian teratoma, and autoantibodies directed against NMDA receptors. That is illustrated by this immunohistochemistry because it's autoantibodies that recognize specifically some dots in the hippocampus of animals. Here is indirect immunohistochemistry on rat brain. You can see the staining only in the hippocampus. One particularity is that the first patients have been described in association with ovarian teratoma, but very quickly, patients without tumors have been described, and many patients have no cancer. And so we leave paraneoplastic syndromes to describe patients with autoimmune, idiopathic cases of autoimmune reaction against the central nervous system. And so this description from Joseph Dalmau of NMDA receptor encephalitis was very important. And you can see here the typical woman. She was 18 years old. She developed subacutely psychiatric symptoms, and she was hospitalized in psychiatry, where she developed seizures and abnormal movement. You can see the typical buccofacial dyskinesia of this disease, and dysautonomia necessitating tracheotomia. She had an ovarian teratoma that has been removed, and circulating autoantibodies against NMDA receptors in the CSF. And very quickly, the first description, Joseph Dalmau described 13 patients, but 1 year later, after the identification of the antigens and after the developing of a test, he was able to publish the first 100 patients. And one very important effect of the description of this disease is the ability to improve with immunological treatments. It's the same woman. You can see 2 years after the episode of encephalitis, and this patient was able to improve completely and to be cured with immunomodulatory treatment like immunoglobulin, plasmapheresis, cyclophosphamide, or rituximab. And it was very important because in paraneoplastic neurological syndromes, the symptoms was linked with neuronal death and destruction of neurons. In the case of NMDA receptor encephalitis, it's not a death of neurons, it's a blockage of the functioning of the neurons. And so it's very important to, for the first time, describe disease that can be cured by immunomodulatory treatments. And these patients may have a total normal life and have babies after the disease and babies without particular abnormalities. And so very quickly, after the description of the first 100 cases, Joseph Dalmau was able to say that it was this disease was characterized by the presence of autoantibodies in the CSF, but with a very specific clinical presentation. And so now the clinical presentation of the patients may lead to the correct diagnosis. So it's young women between 15 and 35 years old, start with prodromal symptoms, not specific headache, low-grade fever, or viral-like illness. And 15 days later, in most of the patients, they develop psychiatric symptoms, and most of the patients will be hospitalized in psychiatry before to develop abnormal movement, dyskinesia, movement disorder, seizures, autonomic instability, and 66% of the patients will be hospitalized in ICU, and most of them will be ventilated. And it's very important in the onset of the disease to look at carefully the dysautonomia, because you may have cardiac or respiratory dysrhythmia with a risk of sudden death. The frequency is clearly a rare disease. In France, at these times, is between 35 and 40%, 35 to 40 patients per year in France, and 40% are children, as we will see. So very quickly, this disease has been described in children, and you can see the abnormal movement and the orofacial dyskinesia in these children. We will see that the clinical presentation is a little bit different, and children are less frequently go to ICU, and the dysautonomia are less frequent in children than in adult patients. So in fact, the clinical presentation vary according age and sex. You can see this work that we performed in 2018 in children with NMDA receptor encephalitis less than 12 years. In fact, the complete clinical presentation is preceded by localized seizures in 30% of patients, or focal unilateral motor seizures, and behavioral disorders is less than 1/4 of the children. And so the clinical presentation of children is a little bit different than adult women. It's the same for the first symptoms in men with NMDA receptor encephalitis. Is very rare. Men are less than 5% of the total of the patients with NMDA receptor encephalitis, adult men. Because in children, it's 50-50 between boys and girls. But after the puberty, it's mainly women who are able to develop NMDA receptor encephalitis rather than men. But the first symptoms are mainly partial epilepsy in men rather than behavioral abnormalities. And so it's very important to evoke the diagnosis. If you are a man with partial epilepsy and normal brain MRI, you have to think about NMDA receptor encephalitis and to perform a CSF study to look at for NMDA receptor antibodies. The median delay between the first symptoms and the partial seizures and the development and behavior abnormalities is 12 days, but it could be longer in some patients. So what about the psychiatric symptoms? The first question was, may we have particular psychiatric symptoms in women with NMDA receptor encephalitis? You can see this one. You can look at, in fact, there is not only the psychiatric symptoms, but also abnormal buccofacial dyskinesia and also catatonia. She kept her leg like this during 3 days, and she also hit her fingers. It was necessary to amputate 2 of her fingers. So she had hallucination and it was difficult to maintain her. But you can see among 65 patients that was hospitalized in psychiatry with anti-NMDA receptor encephalitis, there is no specific psychiatric symptoms. Most of them had hallucination, visual or auditory, but you can also develop depressive symptoms, manic symptoms, mystical ideas, erotomania, anorexia, bulimia. So nothing is specific and everything can be observed. One important thing is the frequency of neuroleptic malignant syndromes in this patient. And so if you have an abnormal reaction of neuroleptics in these patients, you have to think about NMDA receptor encephalitis. On the opposite, we tested a lot of patients, young women with psychiatric symptoms, and clearly NMDA receptor encephalitis is rare, and there is many other origin of the psychiatric symptoms. What happened for the patients and why they come back to the diagnosis of NMDA receptor encephalitis? You can see that this publication from 2016 of 111 patients, 68 have been managed in somatic department, but 2 of them was oriented after that to psychiatry because of the abnormal behavior. And you can see that 43 have been hospitalized directly in psychiatry, and the average duration of stay in psychiatry was 12 days with a median of 7 days. But some patients were stay in psychiatry more than 3 months. And what was the cause of the mutation to somatic department was fever or hypothermia in 44% of these patients, and most of them was suspect of malignant reactions of neuroleptics. So it's very important to keep in mind that if a young patient develop malignant syndromes after neuroleptics, you have to think about NMDA receptor encephalitis. 22% developed clonic seizures, and 33% was other reasons if the family insists to have other examination, EEG abnormalities, MRI abnormalities, or only abnormal movements or neurological suspicion of something. And so it's very important to insist that the psychiatric symptoms are not specific, and that the psychiatrists have to think about NMDA receptor encephalitis in some patients, because the diagnosis is not so easy. CSF is inflammatory in 95% of cases, but most of the times it's only the presence of oligoclonal bands. And so people have to test oligoclonal bands in the CSF. The EEG is abnormal in a very high percentage of cases, but in most of the cases, it's not specific, with only slow waves and sometimes delta brush, that is quick spikes in slow waves. Now the EEGists are more aware about this pattern, but it's sometimes difficult to identify, and it's very important to perform an EEG in all patients hospitalized acutely in psychiatry. Brain MRI is abnormal in 30 to 40% of cases, but really unspecific. Sometimes you may have hypersignal of the hippocampus or some aspecific hypersignal. So it's not a big help of the brain MRI. And so to do the diagnostic, the only way is to identify the NMDA receptor antibodies in the CSF of the patients, and to perform, as Joseph Dalmau, a direct immunohistochemistry to see the typical pattern staining of hippocampus, and to perform the cell-based assay with transfection of NMDA receptors, and to perform indirect immunohistochemistry with IgG labeled in red, and to see that only the cells transfected with NMDA receptors are recognized by the IgG of the patients, demonstrating that there is anti-NMDA receptor 2 antibodies in the CSF. The presence of anti-NMDA receptors in the CSF is pathognomonic of NMDA receptor encephalitis. What about the improvement? Complete improvement of the patients occur in 80% of cases, but it's very long. It's illustrated by these patients. In March 2013, she was hospitalized in ICU without ventilation. You can see the orofacial dyskinesia. In October, after immunoglobulins and rituximab, she was able to discuss, but she was hospitalized in psychiatry. She refused to eat anything. And 1 year later, you can see her, she completely cured, and you are able to discuss, and she completely improved. But it was 1 year, and you can see that the median of improvement is 3 months, and the median of cured patients is 1 year. So we don't know why, but even if you do the diagnosis and treat the patients, it's very long to improve, and it's illustrated on this diagram. It's the month, 0 to 2 years, and the modified Rankin scale, 6. Unfortunately, you're dead, and you can see that we lost some patients because of dysautonomia at the onset of the disease. 5, you are bedridden. 0, no signs. And you can see that at 24 months, most of the patients, 80% of the patients, are MRS between 0 and 1, and so are totally independent and go back to their work. But you can see that the evolution is very long, and 2 years in a woman of 20, it's very long, and the change in the life of this woman. What we learned from NMDA receptor encephalitis, we learned a lot. As I told you, first, it was the clinical presentation was very standardized, so it was possible to evoke the diagnosis with the clinical presentation. The second important thing is that according to the age, the percentage of paraneoplastic origin varies. It was an article from Joseph Dalmo in 2011, and you can see that it was around 50% of cases between 19 and 24 years old. But now the presence of ovarian teratoma is less than 20% in women. So more and more idiopathic cases. And the very important point was the evolution of the patient, the decrease of the autoantibodies during the evolution, and the clinical improvement, and the fact that, in fact, it was a blockage of the neuronal functioning and not a destruction of the neuron, suggesting that autoantibodies could play a role. We obtained a few biopsy or autopsy of patients, and we observed accumulation of CD20 cells, and so B cells in the brain of these patients, and not T cells, as we observed in patients with paraneoplastic neurological syndromes. And so it's a completely different disease. T cells and macrophages in patients with paraneoplastic origins, and B cells in patients with NMDA receptor encephalitis. Another important point is that if you use drugs to block NMDA receptors, you will observe exactly the same symptoms. And one is very important, is ketamine, that is largely used in anesthesia. If you use ketamine and you increase progressively the level of ketamine in a patient, you will observe all the signs that we observe in patients with NMDA receptor encephalitis, such as psychiatric symptoms, hallucination, seizures, abnormal movement, at the end, coma and catatonia. And so this, you can suspect that the autoantibodies may play a direct role in the disease, and many different authors demonstrated this. You know that the NMDA receptors is it's 4 different fractions, 2 NR1 and 2 NR2A, B, C, D, depending of the receptors. And so with Laurent Groc, in 2012, we performed different studies in neuronal culture. You can see a neuronal culture with the staining of the synapse in green and NMDA receptors in red. And we were able to measure the movement of the receptors. For example, you can see here the movement of the NMDA receptors, sometimes in the synapse and sometimes outside the synapse. And in the first minute, in presence of control IgG or IgG directed against NMDA receptors from patients, you can see that you modify completely the movement of 2A NMDA receptors. In control, it's around the synapse, but it's outside the synapse in the presence of anti-NMDA receptor antibodies. And 2B is a large movement outside, around the synapse, but blocked in presence of anti-NMDA receptors. And if you look at the internalization by CEPs, you can see in control condition the fluorescent expression of the receptor at the membrane of the cells in culture neurons, but an internalization and disappearance of NMDA receptor in the surface of the membrane in presence of NMDA receptors. And if you look at during the time, 20% of receptors are internalized after 2 hours of incubation with NMDA receptors, and more than 50% of the receptors are internalized 20 hours after incubation with the antibodies. So there is a direct link, a direct role of autoantibodies, and we demonstrated that it was because autoantibodies block the interaction of the receptors with F1B2. So there is a pharmacological role of the autoantibodies that can explain the blockage of the neuronal function, because NMDA receptor is the main receptor of the glutamate in neurons, but cannot explain all the symptoms that we observe, because if you inject in different mice the NMDA receptors, we can observe some hippocampus dysfunction, but not all the signs that are observed in patients. And there is probably a mix between the action of the autoantibodies and some other things, such as secretion of different cytokines, that can explain all the neurological signs of the patients. But after this first description of autoantibodies against NMDA receptors, Joseph Dalmau and others described many different autoantibodies directed against membrane or intracellular antigens, describing different kinds of autoimmune diseases affecting the central nervous system. So, according to the autoantibodies, they can be paraneoplastic or not paraneoplastic, such as LGA1 or Casper2. And so we change the concept. If you have an intracellular antigens, that is the case for HU, YO, or CV2, it's a good biomarker of cancer, and so it's a paraneoplastic syndrome. It's mediated by immune reaction, but mainly T cells. There is no direct role of the autoantibodies, and it's associated with neuronal death. And you may have other autoimmune encephalitis with NMDA receptors, AMPA receptors, GABA-B receptors, DNR. It's not always associated with cancer. It depends on the autoantibodies. For example, DNR is associated with cancer. GABA-B is only in 2/4, and AMPA receptors or NMDA receptors is less than 20% of patients that are paraneoplastic. There is a direct role of autoantibodies, and there is no or limited neuronal death, and so the patients can improve with treatment, immunomodulatory treatment. And there is some other autoantibodies that we cannot classify. And so a lot of autoantibodies have been described in association with limbic encephalitis. We cannot present all of them, but I will speak about some of them to discuss the mechanism. One is anti-ACA5 limbic encephalitis that was first described by Joseph Dalmau, but we published a first series in 2017. It's a median age of 44 years, and the patients develop subacute anterograde amnesia and pure anterograde amnesia. It's highly inflammatory. You can see the brain MRI with the hypersignal by FLAIR sequence. The CSF is inflammatory in all the cases, with increase of tau protein, but phosphotonormal. And very quickly, you can see hippocampus atrophy because it's associated with neuronal death. But it's a localized neuronal death only in the hippocampus without diffusion on the other area of the brain. It's highly inflammatory. You can see the macrophages and the presence of granzyme B. there is a destruction of the hippocampus and after stabilization, but the patients are still with anterograde memory disturbances. So it's a particular mechanisms. Another mechanism is with anti-LG1 antibodies with a very particular signs called brachiofacial dyskinesia as observed in these patients. You can see another example here or here. It's present in 30% of patients. It can be bilateral or homolateral, and it's pathognomonic of LG1 encephalitis. But the particularity of this encephalitis that it's very different than patients with anti-NMDA receptor antibodies, because the presentation is not acute but chronic with abnormal faciobacral dystonia or hippocampus involvement or cognitive disturbances. The particularity is that the CSF is not inflammatory in most of the case. And so it's an encephalitis. There is a presence of autoantibodies and abnormal of a specific HLA haplotype, DRB10701. So many arguments to think that it's autoimmune, but no CSF inflammation. But in most of the case, you can see T2 hyper intensity in the limbic system. And as in patients with NMDA receptor autoantibodies, if you treat these patients with immunomodulatory treatment, you will have cognitive improvement, and in most of the patients, complete improvement of the patients. But it's not exactly the same that patients with anti-NMDA receptor autoantibodies, even if some authors described a direct role of the autoantibodies to modify the interaction of LG1, who is a secreted protein in the synapses, with ADAM proteins, explaining the neuronal dysfunction. Another example is encephalitis with Caspr2 autoantibodies that have been described in 3 different groups of patients. Patients with Morvan syndromes, it's abnormal behavior, abnormal sleep, and dysautonomia, or patients with limbic encephalitis, and we will see that they can develop ataxia, or patients with neuromyotonia. We look at in the group of patients with anti-Caspr2 encephalitis is the work of Bastien Joubert, who is now published. And we look at the onset of the disease. In fact, in most of the patients, it's not limbic, it's limbic symptoms in less than 50% of the patient, and very discrete with some temporal seizures, but rare, and temporal dysfunction, but not so easy to identify. And in 17% of patients, it's sensory neuropathy of small fibers involvement, and some of them may develop cerebellar ataxia. And you can see that you may have the ability to do the diagnosis more than 10 months after the onset of the symptoms. So it's very difficult to diagnose anti-Caspr2 encephalitis, because the symptoms are very weak and very different than the acute symptoms observed in patients with NMDA receptor encephalitis. And sometimes you may observe the paroxystic ataxia. You can see this patient with his dysarthria,
Mets-toi debout, pieds joints.
You can see the ataxia
Fais les marionnettes.
and the dysmetria, adiadochocinesia.
Mets le bout du doigt sur le bout du nez, comme ça.
It's typical of cerebellar
Le 33e régiment
ataxia.
de cavalerie.
Le 33e régiment de cavalerie.
And
Le
you
vase est dans
can
la salle à
hear
manger.
the dysarthria
Méchant.
Contraire de beau.
Les.
who completely
33e
disappeared
régiment de cavalerie.
Le 33e régiment de cavalerie.
after a few seconds. These patients have no dysarthria. So it's a paroxystic cerebellar ataxia, and it's very interesting because these kind of symptoms have been described in genetics in patients with mutations of potassium channels. We checked in these patients the potassium channel that was normal, but we know that the role of Caspr2 is to clusterize potassium channels, and this patient totally improved after immunomodulatory treatment, and this cerebellar ataxia completely disappeared. And we observed that this kind of paroxystic cerebellar ataxia can be present in 30% of patients with Caspr2 encephalitis. The last kind of patients is more surprising, is patients with AGLON5 autoantibodies. It has been described by Joseph Dalmau and Frances Gross in 2014 in patients with abnormal sleep and rapid eye movement parasomnia. You can see one patient from Lyon with chorea. It's an autoantibody that recognizes the target. We don't know the role of this target in all the brain of the mice and neurons in cultures. And it was described in a mean age of 59 years old with clinical presentation that looked like neurodegeneration with REM parasomnia, brainstem involvement, dysautonomia, but CSF, MRI, and EEG are normal, and it's associated with a particular HLA haplotype. So autoantibodies and HLA suggest an autoimmune origin. But the first autopsy of this patient that were present because they developed dysautonomia and sudden death, there is abnormal tau deposit, phosphorylated tau, suggesting neurodegenerative disease and no inflammatory cells. But some patients are able to stabilize with immunomodulatory treatment. So it's a mix between immune disease and neurodegenerative disease. So it's a very important disease to look at. And recently, some Dutch group published that there is two kinds of patients with subacute or chronic development of the disease, and it's mainly on the brainstem syndromes with something that look like neurodegenerative diseases. So it's opened a new area of autoimmune disease that look like neurodegenerative. So what are the mechanisms of autoimmune encephalitis? With Virginie Desestres, we worked on the immune breakdown in the tumor of patients with paraneoplastic syndromes, and we clearly identified that the tumor provoke the immune breakdown with mutation of the antigens and other expression in the antigens, specifically in the tumor of patients with PNS and paraneoplastic syndromes, and some abnormality of the genes with other expression, gain of expression and mutations of the antigens recognized by the autoantibodies in this patient. And so we think that in patients with tumor, the immune breakdown, the origin of the immune breakdown is in the tumor. But what about the patient without a tumor? We look at first, we have HLA haplotype and the subtypes of HGG. And we identified a group of patients with IgG4 and not IgG1 associated with specific HLA. It was patients with limbic encephalitis and Cas2 antibodies, LGA1 antibodies, IGLON5 antibodies, and some other with IgG1 that could be T-cell mediated, for example, in ACA5 patients, or not in NMDA receptor encephalitis, but there is no IgG4. Sometimes there is an haplotype 8.1, mainly observed in patients with autoimmune disease. And for example, in patients with GAD65 antibodies, most of them have a family history of autoimmune disease, and it's not the case in patients with other autoantibodies. So it's probably heterogeneous in this group. And in paraneoplastic cases, there is no HLA association, and it's always IgG1, like in the second group. So it's clear that the mechanism is different according to the autoantibodies, and we have at least 4 different evolution of mechanisms of autoimmune involvement in these patients. Some of them associated with IgG4 and class 2 HLA haplotype, some other clearly linked with the tumor, and an heterogeneous group with IgG1, some of them T-cell mediated, some other B cells mediated. So it's clearly a rare disease. It's around 3.1 and 7.1 per million person per year, but highly interesting disease to understand the relationship between neurodegeneration, neuronal functioning, and autoimmune immune system. To diagnose this patient, it's very important to look at which kind of techniques are used, because you may have commercial line blots, but we saw that, for example, YO antigens, we observed using these commercial line blots more than 90% of false positive. And so it's very important to use different techniques, Western blot, immunohistochemistry, cell-based assay, to be sure of the positivity of the patient before to conclude that it's an autoimmune disease. So this point is very important, and the expert center are very important to be sure of the relationship between the identification of an autoantibodies and the disease. And so to conclude, autoimmune encephalitis are rare, but a new syndrome is described every 6 months. So it's very important to understand the relationship between autoantibodies, symptoms, and mechanisms of the disease. They must be classified according to the associated autoantibodies. And we saw that anti-ACA5, for example, is totally different on the mechanism that NMDA receptor antibodies. Clinical characteristics are associated with each autoantibody. So semiology is very important to think about the possible cause of the disease and the identification of the autoantibodies. CSF is not always inflammatory, and so you may have autoimmune disease without inflammation in the CSF. Autoantibodies must be confirmed by expert centers. Immune mechanisms vary according to the associated autoantibodies. Also, in the future, the treatment must be adapted according the mechanisms of the encephalitis, but at these times, no treatment are codified because it's rare disease, and so it's difficult to perform clinical trials. And IGLON5 suggests that links are possible with neurodegenerative disease, and it will be very important in the future to develop animal models to understand exactly what's happened in the patients. So it's a group that are working in Lyon with us to describe all this disease, and you may have more information and all our article in the website that is easy to see. Thanks a lot, and I can answer to some questions if you have them.
Thank you very much, Professor Honorat. In the chat, I can see a question that says, excellent presentation. For how long do you keep immunosuppression in patients with a clinical picture of NMDA encephalitis but negative antibodies performed later? It's an 11-year-old girl that was treated with steroids, plasma exchange, IVIG, and currently on mycophenolate mofetil.
I think that it's very difficult if you do not have biomarkers to be sure of the diagnosis. So the first is to discuss all the differential diagnoses, because I think that is a little bit dangerous to treat with immunomodulatory treatment a patient without clear diagnosis and the identification of autoantibodies. Sometimes the autoantibodies may be at low level, and so it's very important to send the samples to expert centers. I think that it's the first answer, to discuss the patients with expert centers before to use a long-time treatment with immunomodulatory treatment in patients without autoantibodies. In patients with NMDA receptor autoantibodies, in France, we treat them until the total improvement of the patients, and after that, we stop the immunomodulatory treatment.
Yeah. Thank you very much. We also have the same experience that this question, in fact, has two different questions. One is in positive patient, for how long do you treat? And we have similar experience that when the patient is recovered, we don't continue with chronic immunosuppression. And also, I completely agree that in antibody negative patients, it's very important to be very careful, no? And first of all, to test in research laboratories that, because maybe it's not antibody negative, no, maybe it has an antibody that is not included in commercial panels, and also that in truly antibody negative patients, you should be very careful in giving aggressive immunotherapy, because the diagnostic differential can be very broad, no? Kumaran, yeah. What do you think?
I completely agree in what you're saying, indeed, and we have the similar experience also. I think there is another question from the chat, the question box, and it's from Alexandre Bello. Thanks, Jerome, for the great talk. Are there any specific cytokine abnormalities in the limbic or other encephalitis?
And it's not well studied. Many different groups in few patients try to study the cytokines level in different kind of patients. It's clear that it's different according to the associated autoantibodies, but it's not so clear which kind of cytokines are involved in these patients, and we need to work more carefully to know exactly what is the mechanisms. And obviously, interleukin-6 is mainly studied to use the specific immodulation, but it's not so clear at this time the role of cytokines. I don't know if Thais has other experience on this aspect, but
no, it's very similar also. Yeah, I'm trying to see the questions, but I don't see very well the place.
Yeah. I can't hear you, Jerome.
Yeah. One question
sorry,
is.
Now I can hear now.
Yes, about the treatment, if it's different in adults and children, especially the duration of the immunosuppression. No? I guess this is in relation to NMDA receptor encephalitis, but this is answer, no, because Jerome Honorat is seeing adults and we, Kumaran and me, and seeing children, and all of us say that until the resolution of the symptoms, no. I think probably that since we use rituximab almost as first line drug, no, because in most of the patients require rituximab, probably the risk of relapses has decreased, no, since first series that didn't use this type of drugs.
In fact, there is no clinical trial, so it's very difficult to answer about the best treatment for the patients. But the experience seems to be the same around the world, to first try immunoglobulins and corticosteroids, and to use rituximab, probably more early in children than in adults. But most of our adults treated receive rituximab because after 2 course of immunoglobulins, there is no effect, obvious effect. But also, when we look at the evolution, the median of the evolution of the improvement of the patient is 3 months, and 3 months is very long in a patient with encephalitis. So we don't know exactly what the best treatment for these patients.
I think in a previous question in the email, no, some were interested in to know your opinion about the bortezomib immunotherapy or other type of immunotherapies, no? I can add also tocilizumab in the question.
Yeah, I think that it's exactly the same. We don't know for the 2 first line, and so we don't know exactly what could be the best for the 3rd line. We use what we can according the evolution of the patient, of the improvement or not. I think that it's probably very interesting treatment for some patients, but we need more studies to know exactly how to use these drugs. It's too early to have a clear answer, but I agree that we have to consider these drugs if there is no improvement of the patients. But first, we have to be sure that these patients have been treated correctly in 1st and 2nd line before to think about a 3rd line, because we have clearly no data to think that these drugs will be better than the others in these patients.
Yeah, completely agree. And also, sometimes it's very difficult to see if the effect that we are seeing it's from the 3rd drug that we have added or from the previous one, no? Because as you very well described, that these patients have a very slow recovery, and maybe if we add another drug, we can see beneficial effects, but maybe we are seeing the delayed response of the rituximab or cyclophosphamide, no? And it's important to keep in mind that in some care reports in the literature, maybe we can see this type of effects, no? That also the bias publication effect.
Yeah, and it's very important to keep in mind that you may have some surprise, even in patients who have a lot of symptoms, 2 courses of immunoglobulins, you may have a total improvement of the patients. And for the future, I think that it's better to treat them by immunoglobulins rather than to use new drugs or rituximab or cyclophosphamide in these patients if they can improve only with corticosteroids and immunoglobulins.
Kumaran, do you have similar experience?
Yeah, well, I'm sorry, it disconnected, and so so of course, yes, we need to follow on the new treatments, and we need more data in order to conclude on these specific things. And I also think that time is running out, please. more than running out. So maybe we can conclude. There is a last question, maybe a short answer. It's more pediatric, but nevertheless, Jerome, you can try. Can you comment on the approach to children with resistant epilepsy?
Not really, because they are children first, and secondly, in fact, we tested a lot of Norse syndromes, and all of them were negative for particular autoantibodies. It's like Oxoclonus, Norse, Fides, Virus, and so I don't know. I have no particular advice how to treat this patient except to stop as possible it is for the seizures. But we don't know. We have no clues to understand the mechanisms of the inflammation in these patients. And in most of the time, if it's recurrent seizures, isolated, if it's not GABA B receptors positive, we have no particular autoantibodies associated with this patient.
I think for this resistant epilepsy, it's still a wide area of investigation, and we need to find out new autoantibodies. And of course, all the treatment that are proposed are going to be more kind of what we experienced actually. So well, Thais, any other comment, and then we can wrap up, I think.
Yeah, no, I really share the opinion of Professor Honorat, because in these cases we don't know the etiology, and we are not sure that it's completely that is autoimmune diseases, no? Because maybe it's a box of diseases that, because even metabolic or genetic diseases can be triggered by fever or by other infections, no? And it's important also to keep in mind also in the balance of risk-benefit of immunotherapy, no? But for sure we need further data for these recommendations of immunotherapy in these patients. And to conclude, thank you very much, Jerome. This was a really nice pleasure, this very clinical overview and the review of the physiopathology of this autoimmune encephalitis, and I think we enjoyed very much the session.
Thank you very much.
Thank you all. Thank you very much.
Thank you.